Hello,
Hi, good afternoon, Dr. Ola.
you are set?
Yes, good to go.
Okay, let me speak with the Ramat. Ramat, is she there?
Hello. Hello, she's not present, but I'm here in place of her.
Okay, who is the admin today?
I am here.
Okay, okay. So I just want us to have once we have up to like 15 people, then we'll start. So I think we're about 14 now. Okay, okay, we're 15. Okay, so just a minute.
Hi, good afternoon, everyone. My name is Dr. Chelsea Roy. I'm a medical officer at the Heart Institute of the Caribbean, and today I will be presenting on hypertrophic cardiomyopathy. And I've entitled my presentation, The Enigmatic Hypertrophic Heart. If at any point you can't hear me properly or need me to repeat something, please just let me know. So we'll be looking at an introduction to cardiomyopathy, and you'll hear me saying HCM. That is me referring to hypertrophic cardiomyopathy. So for HCM, we'll be looking at, sorry, Doc?
You can go ahead. Go ahead.
Okay. For HCM, we'll be looking at the definition, the background, briefly looking at the historical perspective, genetic basis, morphology, patterns of HCM, pathophysiology, clinical features, clinical course, management, screening strategies, and a case to wrap up the presentation. So what is cardiomyopathy? This is a myocardial disorder in which the heart muscle is structurally and functionally abnormal in the absence of coronary artery disease, hypertension, valvular disease, and congenital heart disease, sufficient to cause observed myocardial abnormality. So for the types of cardiomyopathy, there is hypertrophic cardiomyopathy, which is what we'll be looking at today, dilated, restrictive, Takotsubo, and chemically induced cardiomyopathy. So hypertrophic cardiomyopathy, this is primarily a genetically determined heart muscle disease, most often in 60 to 70% of cases, caused by mutations in one of several sarcomere genes, which encode for components of the contractile apparatus of the heart. So here we have a diagram, and we see the normal heart on the left and the hypertrophic cardiomyopathy on the right. So we see that the left ventricle, there's hypertrophy to the wall, and there's a thickened interventricular septum. And we'll speak more about this when we go on to the morphology and the pathophysiology. So as we mentioned, this is a genetic disorder, and it is inherited in an autosomal dominant fashion, and it is the leading cause of sudden cardiac death in pre-adolescence and adolescence, which is actually a big part of why I wanted to do this presentation, as it's a common cause, or the most common cause of death in young persons or athletic young persons. So the hallmark of this disorder is that there's myocardial hypertrophy that is inappropriate and often asymmetrical. That is what will help you differentiate it from a lot of the other causes of hypertrophy and cardiomyopathy. And it occurs in the absence of any obvious inciting reason for the hypertrophy. The hypertrophy can occur anywhere in the left ventricle. Let me just go back. Hold on, sorry. It's going forward. So the hypertrophy can occur anywhere in the left ventricle, but predominantly it affects the interventricular septum, resulting, can everybody see my cursor, by the way? Resulting in left ventricular outflow tract obstruction.
Yes.
Okay, thank you. So for the incidence, the prevalence of HCM is 0.05 to 0.02% of the population. The prevalence in North America, Africa, and Asia is about 1 in 500 individuals, and approximately 25% of first-degree relatives with HCM show morphological evidence on an echo. And this highlights the importance of the genetic component and screening, which we'll get to a little later in the presentation. There's a 2-to-1 ratio with men to women and a 2-to-1 ratio African Americans to Caucasians. Briefly looking at the historical perspective, it was first described in 1958, but first clinically diagnosed in the 1960s. And there's some other names that we might have come across for the same disease. So idiopathic hypertrophic subaortic stenosis, muscle subaortic stenosis, or hypertrophic obstructive cardiomyopathy. And that's actually the term I learned in school. But today we'll just be saying HCM. The genetic basis is autosomal dominance with incomplete penetrance. And there are more than 9 different sarcomere genes with over 1,400 mutations that have been implicated. But even though there are that many, there are 2 main ones that are seen in 80% of patients, a mutation in either MYH7 or MYBC3. And at the level of the sarcomere, mutations lead to enhanced calcium sensitivity, maximal force generation and ATPase activity, and abnormal energetics and impaired relaxation due to mutation and hypertrophy are seen. So looking specifically now at the morphology, there are actually different patterns of HCM, and it can be characterized with, well, different morphologies or different patterns. So it's asymmetric, left ventricular hypertrophy. Typically, one or more regions of the left ventricular wall has a greater thickness than the other, and there's sharp transitions in thickness between adjacent areas. But as we mentioned, there's not one classic morphology. We actually have quite a few. So we have our sigmoidal HCM, which is the most common, 40 to 50% of patients. And we see that here. So we have a diagram and then the echo image below. So we see that there's a septal protuberance and there's a concave septum. This is the most common morphology. There's the reverse curve HCM, which occurs in 30 to 40% of patients. And there's a convex septum and concentric left ventricular cavity. There's apical HCM, which occurs in 10% of patients. And there's apical hypertrophy, so this region of the left ventricle. And on echo, there's an ace of spades appearance. And I believe there was a presentation done on specifically apical HCM a few months ago because there was a case that we had at HIC. There's also neutral HCM, which is the other 10% of patients when the septum is just straight, like what we're seeing in this image. Now on to the fun part, the pathophysiology. Once we understand the pathophys of this disease, we can understand the signs, the symptoms, and pretty much everything else that comes along with HCM. So there are 4 interrelated processes with hypertrophic cardiomyopathy. There's left ventricular outflow tract obstruction, diastolic dysfunction, myocardial ischemia, and mitral regurgitation. So we're going to look at a diagram as we describe this. So firstly, the left ventricular outflow tract obstruction, So here we see the interventricular septum is thickened, which is one of the hallmarks of this disease. And that causes a narrowing at this area. And that is a part of what causes the left ventricular outflow tract obstruction. But what also happens is that there is systolic anterior motion, something that we call SAM, so systolic anterior motion of the anterior leaflets of the mitral valve. So what happens is that the mitral valve is pulled up against the septum here, like we can see happening in this image. And this happens because of the contraction of the papillary muscles, which occurs because of the valve's abnormal location, and the septal hypertrophy alters the orientation of the papillary muscles. When the mitral valve is drawn up, like in this diagram, towards the septum because of low pressure that occurs as blood is ejected at a high velocity through the narrowed outflow tract, and this is called the Venturi effect. The interventricular septum thickens and pulls the mitral valve closer to it, and this also results in mitral regurgitation. So just going over that part briefly. Basically, this part of the mitral valve is pulled inward towards the interventricular septum. That, along with the thickened interventricular septum, worsens this narrowing and worsens the left ventricular outflow tract obstruction. So it's difficult for the blood to leave the left ventricle and go to the aorta. The mitral regurgitation now is because you have the pulling of these leaflets of the mitral valve. The elongation then causes blood to be able to flow back from the left ventricle into the left atrium, resulting in mitral regurgitation. So everything is kind of interrelated. There is also diastolic dysfunction. So in hypertrophic cardiomyopathy, the heart muscle it's hypertrophied. So as regards to contracting, that strength is there, or in systole. But with diastole, there's impaired relaxation. So the heart cannot relax how it should to then fill with blood properly, which is what should happen in diastole. And this is the contributing factor in 80% of patients, and there's non-uniform ventricular contraction, high systolic contraction, and diffuse ischemia results in stiffness of the wall of the ventricle. So as it regards to the myocardial ischemia, there are actually a few postulated mechanisms. Well, one of which is that same thing with the left ventricular outflow tract obstruction. If the blood can't get to the aorta, then the blood is not going to the coronary arteries. So the heart itself is underperfused, and that results in myocardial ischemia. Some other postulated mechanisms about the myocardial ischemia are abnormally small and partially obliterated intramural coronary arteries as a result of the hypertrophy, as well as inadequate numbers of capillaries for the degree of left ventricular mass and increased myocardial oxygen consumption. So those could be reasons as well why there's ischemia. And then remember, when you have ischemia, you have cell death, and that leads to fibrosis, and all these things impair the contractility of the heart, impairs how the heart would relax as well. So those are the main things as it regards to the pathophysiology. And then this now ties into the clinical presentation. So if you're having myocardial ischemia, you'll have chest pain, you'll have angina. So that's why these patients could present with symptoms like chest pain. Also, these patients could present with arrhythmias, palpitation, irregular heartbeat, and that is because of the thickened septum. When you have these changes in the wall of the heart, then it affects the conductive pathway, and that would then result in arrhythmias and palpitations. The left ventricular outflow tract obstruction causes a decreased cardiac output. So then we would have symptoms of a decreased cardiac output, such as dizziness, fainting, fatigue, lightheadedness. So once we understand that, we can understand the symptoms that a patient comes with. And conditions of low preload, such as dehydration, and low afterload, such as arterial vasodilation, also would worsen this condition. So the maneuvers that let me go on to physical, and then I'll describe that there. So for sudden cardiac death, this is actually some patients, this is how they present. So they might not have had a previous history of any medical illness, any cardiac illness, no symptoms at all, no chest pain, no arrhythmia, nothing. And then you just hear that they're playing a football game, basketball game, and suddenly collapse. So some patients, this can be how they present at first. And that's really important to know. And that's something I really wanted to highlight in this presentation, as it's the most common cause of sudden cardiac death in young people, including athletes. So anybody with unexplained syncope, family history of sudden death, abnormal exercise pressure response, those are patients that we would have to work up for HCM. And this chart is just highlighting that HCM is the most common cause of sudden cardiac death in young persons. We can see here 35%. And then there's also an indeterminate section as well. So it could even be more. So for the physical examination, before I go into the physical examination, I just want to speak about some of the maneuvers that we would do when we're examining these patients. So we would say when the patient squats, and squatting increases the blood going to the heart, increases the preload. So squatting would actually decrease the murmur or decrease the left ventricular outflow tract obstruction, which is not the same for most other murmurs. For most murmurs, more blood flow worsens the murmur, it exacerbates the murmur, and less blood flow improves. It's the opposite for HCM. More blood flow actually helps to widen that area that is narrowed and helps to relieve the left ventricular outflow tract obstruction. So that is why squatting would lessen it, and then a Valsalva, which decreases the blood flow to the heart, would worsen it. So on physical examination, patient could have bifid carotid pulse. For the JVP, there could be a prominent A wave. For the apical pulse, there could be a double and triple apical pulse. And for the heart sounds as well, there can be a few changes. So for S2, we know that we have a physiological S2 split, which is when the aortic valve would close first before the pulmonic valve. However, in HCM, because the blood is taking such a long time to get to the aorta, the aortic valve closes after the pulmonic valve, which is why we have the paradoxical split for S2. For patients with heart failure, who develop heart failure secondary to HCM, you can have a S3 heart zone, and the hypertrophy can result in a S4 heart zone. So for the murmurs that you can hear, there's a medium pitched crescendo, decrescendo systolic murmur along the left lower sternal border and apex, and it radiates the suprasternal notch. This murmur is similar to what you would hear in aortic stenosis. It's the location that is different. So for aortic stenosis, it would be along the right sternal border. So this is the murmur that you get from HCM. However, patients could also have the murmur of mitral regurgitation, because remember, that's a part of the pathophysiology as well. So you could also hear a pansystolic murmur that radiates to the axilla for these patients. So now on to our diagnostic evaluation. How do we work these patients up? So we start with our electrocardiogram, or ECG, our Holter monitoring, or echocardiogram. We can do catheterization, even though that's not routinely done. We can do cardiac MRI and genetic testing. So looking at the ECG, abnormal ECG patterns are common in about 90% of patients with HCM. And some of the findings you can see on ECG, there's the left ventricular hypertrophy results in increased precordial voltages and non-specific ST and T wave abnormalities. The asymmetrical septal hypertrophy produces a deep Q wave, which is what we're seeing here, a dagger-like Q wave in the lateral and inferior leads. So even besides the ECG findings, you don't have to remember the ECG findings. Just remember that 90% of patients can have an abnormal ECG. However, what happens to that other 10%? There are 10% of patients with HCM that can have a normal ECG. And with that said, and this is something we should remember in general and not just for HCM, a normal ECG does not rule out any cardiac pathology. Because remember, this is just a snapshot in time. This is just 10 seconds of the heart's electrical activity. So if you have a high suspicion for that patient, given the history, given some of the signs and symptoms that we would have described, if they have a first-degree relative, then continue the workup for this patient. And we'll speak about that a little further down. But what I wanted to highlight here, a normal ECG doesn't mean that the patient does not have HCM, because it's only present in 90% of, an abnormal ECG is only present in 90% of patients with HCM. And before we go on to echocardiography, so for those patients as well where we don't see anything on ECG, we can then go on to do a Holter, because then we'll get a longer representation of the electrical activity in the heart over 24 or 48 hours. And then we can see at that time if we pick up any abnormalities. So for echocardiogram, some of the things we can see is what we would have already looked at when we were looking at the previous diagrams. So there's abnormal systolic anterior leaflet motion of the mitral valve, left ventricular hypertrophy, left atrial enlargement, diastolic dysfunction, small ventricular chamber size, septal hypertrophy, decreased mid-aortic flow, and partial systolic closure of the aortic valve in mid-systole. But even though we have all those findings, what is the diagnostic criteria? So an unexplained maximal wall thickness of greater than 15 millimeters in any myocardial segment is diagnostic for HCM, or a septal to posterior wall thickness ratio of greater than 1.3 in a non-dilated ventricle and greater than 1.5 in the setting of systemic hypertension. But the one I would really want you to remember is unexplained maximal wall thickness of greater than 15 millimeters. That is diagnostic for HCM if there's nothing else that is explaining this hypertrophy. And we can see that here, this is an example. This is not a dynamic image, apologies, but we can see here looking at the interventricular septum that measuring this portion, it is 31 millimeters, which is greater than the 15 millimeters. So this would be diagnostic of HCM and somebody that we'd want to evaluate fully. There's also a role for cardiac MRI, and this is in patients who the echocardiogram is questionable, or if for example, you need to get more information, or for those borderline patients where you're not fully sure, right, and you need to get additional information. So systolic anterior motion of the mitral valve, this is clearly seen on a cardiac MRI. Also, gadolinium contrast cardiac MRI, it's very helpful in differentiating HCM from other causes of cardiac hypertrophy and other types of cardiomyopathy, such as amyloidosis, athlete's heart, and Fabry's disease. Just quickly looking at the histopathology, we can see that there's disorganized left ventricular architecture with myocyte disarray. There's also small vessel disease, remodeled intramural coronary arteriole with a thickened media and narrowed lumen. So that links back into the pathophys of the myocardial ischemia. And then replacement fibrosis, the consequence of silent myocardial ischemia and myocyte death. This myocardial ischemia then results in fibrosis. There's also a role for genetic testing. So for patients who you've confirmed the diagnosis based on their echocardiogram findings and based on their history, you can then go on to do genetic testing for these patients. And also the genetic testing is not only important for the patients, but given how this disease is primarily an autosomal dominant disease, that's how it's inherited. So the family members as well, the first degree relatives, you'd want to do genetic testing for them too, so we can know these patients from early and prevent them from having the complications of hypertrophic cardiomyopathy. Now we're going to go on to the management. So the goals of management is to relieve the symptoms, reduce the left ventricular outflow tract obstruction, prevent sudden cardiac death, and screen and counsel families. So as regards to the pharmacotherapy, one of the main things that these medications do is that they increase the amount of blood in the heart. So they, like, for example, the verapamil, the beta blocker, the sopramide would increase the amount of blood that goes to the heart. And as I mentioned to you earlier, in HCM, more blood to the heart helps to relieve the left ventricular outflow tract obstruction. It helps to reduce that narrowing, and patients have a better outcome and less symptoms as well. So that's how these medications tie in. For patients who have drug refractory symptoms, you can go on to septal myomectomy, which is surgery, or alternatives to surgery have alcohol septal ablation and dual chamber pacing. So a lot of what we spoke about, some persons would have probably learned about that already, but what's new? So there's a new medication on the market, well, about 3 years old, but this is the first ever cardiac myosin inhibitor approved by the FDA in 2022, and it's mavacamten, and this is specifically for the treatment of symptomatic obstructive hypertrophic cardiomyopathy. And what this medication does, it acts as a dimer switch for the heart's contractility. So it binds directly to the cardiac myosin and inhibits its interaction with actin. By doing so, it reduces the number of active cross bridges during each heartbeat. This leads to predictable dose-dependent reduction in the force and cardiac contraction. Okay, what is all of that really saying? Basically, one, it reduces the left ventricular outflow tract obstruction. This is by decreasing the force of contraction. It lessens the systolic anterior motion of the mitral valve. We've mentioned this, SAM, quite a few times because the systolic anterior motion of the mitral valve is what worsens the left ventricular outflow tract obstruction. So if we can lessen that and the Venturi effect that pulls the valve into the outflow tract, then it reduces the left ventricular outflow tract obstruction, and these patients do better. Also, it improves diastolic function. So when you have fewer cross bridges formed, the heart muscle is able to relax more effectively during diastole, improving filling and reducing filling pressures. The third mechanism is that it improves energetics. So there's a hypercontractile state in HCM, and it takes up a lot of energy. By normalizing the contractility, this medication improves the heart's metabolic efficiency, which then may help alleviate symptoms like angina, which is chest pain. All right, so now we're going on to a clinical case, and I'll discuss the screening after the case. So a 17-year-old professional football player with no known past medical history collapsed while on the field during practice and subsequently arrest. He was having exertional dyspnea for a few months prior to this incident, but it did not affect his activity level. He was told when he was a child that he had a heart murmur but it was never formally investigated. He was not taking any medications, and there was no family history of cardiac disease. An autopsy later revealed that the patient had hypertrophic cardiomyopathy. So just to clarify, this is not a case of ours. I'm new to HIC, so I did get this case from the internet, but it's important for us to discuss this because here in Jamaica, how many times on the news have we heard a football player, young football player, somebody just collapsing on the field? And I'm pretty sure that if screening protocols and other things were in place, then we could help to reduce the chance of sudden cardiac death in these patients and pick up this patient population from much earlier. And that is what we need to try to do. So for screening protocols for all athletes and anybody involved in sports at any level, they should have a general medical evaluation to find out about any history, family history. And all patients, all of these athletes should have a baseline ECG. If any of these persons have any symptoms of what we have discussed earlier, palpitations, chest pain, syncope, pre-syncope, no matter what the story was behind that, even if it was a one-off event, if there are any of those symptoms, if there's an abnormal ECG, if there's a family history of a first-degree relative, or actually any relative, a close relative that has sudden cardiac death, that patient is a patient you want to follow up very closely, and that patient needs to be evaluated by the cardiologist and have the full proper workup, because we don't want to take it for granted. Again, going back to the ECG, even if we do the ECG and the ECG is fine, to say that, okay, the ECG is fine, this patient is fine, they can continue playing, because we know that in 10% of the patients, the ECG can be normal. So if there's any suspicion, and if we identify these high-risk patients, then we need to do the proper screening for them and actually try to implement some screening protocols so we don't have the sudden cardiac death of these persons. So as we see here, for primary prevention, we want to, for patients with familial sudden death, unexplained syncope, multiple repetitive NSVT on Holter, abnormal exercise BP response, massive LVH. These are patients we need to work with closely to prevent it from getting to them just having a sudden cardiac death or having some cardiac event that can then just worsen their morbidity, mortality, and when they could have gone on to live a better life, understood what was happening with them, and been on some sort of medication, some sort of management, being followed up, doing their regular checks. So we need to find a way to target this patient population and identify these high-risk patients and get some sort of screening in place going for them. And that is what I have for you today. These are my references. Let me know if you have any questions, and thank you for your time.
Okay, thank you, Dr. Chelsea, for the beautiful presentation, talking to us about hypertrophic cardiomyopathy. Like you said, it is a very important cause subject to discuss because, like you said, is the number one cause of death in active young people. And I think for the sports followers who remember notable athletes that have died from hypertrophic cardiomyopathy. I can remember Mark Ribbenfo, that's a Cameroonian footballer in 2003 that died on the pitch while playing football. And I think Reggie Lewis also comes to mind, a basketballer that also died in 1998 from hypertrophic cardiomyopathy. So it's an important topic to discuss. And so some comment that I want to make, most of these patients majority are asymptomatic, and most of them are actually picked from a carefully taken family history, where you have family, if you are able to get family history of sudden cardiac death, cardiac arrest, or maybe an accident, or maybe somebody just coming to do echocardiogram or something else, and you find left ventricular hypertrophy. So most of the time is most likely you're going to pick these patients up by accident, or maybe when you're fortunate to have a positive family history. And Dr. Chelsea has told us when the LVH is more than 15 millimeter, but in people with family history or maybe with genetic tests, if the LVH is greater than 13 millimeter, that also makes the diagnosis. And like she said, you can have the hypertrophic cardiomyopathy with obstruction or without obstruction. And about 30% of them have left ventricular outflow tract obstruction when the pressure is more than 30 millimeter of mercury. But for some, you will only be able to discover this left ventricular outflow tract of obstruction after some provocation. So some of them may need to go, you may have to put them through exercise echo. So that is also an integral part of screening and diagnosis in this group of patients. So when you see these patients, you've done their ECG, you've seen features suggestive of left ventricular hypertrophy, you've done their echo, you've found hypertrophy, whether it is asymmetrical, which is the commonest, or whether a concentric one, or whether it's the apical hypertrophic, which we talked about before. Then the use of Holter ECG to study if they have post-rulous arrhythmia, the use of exercise tests to find whether they have left ventricular outflow tract obstruction with provocation, because it might be absent at rest. So exercise testing is important for them, and this also will be part of their regular screening. Between every 1 to 2 years, they need to be doing echo, doing exercise echo, doing ambulatory ECG for appropriate follow-up and then appropriate monitoring. And she has done well in discussing the pathophysiology, the clinical features, and the screening. So the other commenter we had will be on the treatment. She has done well that once you understand the pathophysiology, it will be easy to know why we do what we do in the management of these patients. And like you said, the use of beta blocker is very important. Beta blocker, it brings down the heart rate, improve the diastolic feeling, reduce the oxygen demand of the muscles, and all this coming together is able to help the patient. Also, the use of the non-dihydropyridine calcium channel blocker, the verapamil, that also helps the same way with the beta blocker. So you can either do your beta blocker or you do your verapamil. Then other option you have is when you cannot use these two, you can also consider the use of disopyramide. And what you want to do, you don't want to give them a vasodilator, because he talked about anything that reduces the preload or anything that reduces the afterload will worsen the left ventricular outflow tract obstruction. So we don't want to give them the non-dihydropyridine calcium channel blocker. You want to be careful with the use of diuretic in them, because you don't want to reduce your preload. But some of them also present in heart failure. So you have to judiciously and carefully put them on beta blocker so that you don't worsen the preload. And also in them, you also, like she said, because of the forceful contraction, all these are the things that are worsen the left ventricular flow obstruction then. So in this context, when they have heart failure, you also want to be careful with the use of digoxin in them, because because of its positive inotropic effects, can also worsen the left ventricular outflow tract obstruction. So she talked about the use of mavacamten, relatively new, like she said, about 3 years ago, which is a myosin inhibitor. So what it's going to do eventually is going to reduce contractility. So, but when you're giving the patient this, then you have to monitor the ejection fraction closely, because it's going to reduce the ejection fraction. And that means that you will not be able to use this in patients with hypertrophic cardiomyopathy that also has heart failure. And when the left ventricular outflow tract pressure gradient is more than 50, then you have to consider surgical intervention in them. So whether you want to do the septal myectomy or you want to do the arcual septal ablation for them, the two have been found to have good outcome in carefully selected patients. And we should not forget that about 25% of patients with hypertrophic cardiomyopathy also has atrial fibrillation. And atrial fibrillation is actually the commonest arrhythmia in them, even more common than the ventricular tachycardia and also that. So these are patients. So use of Holter to find out whether they have atrial fibrillation, and if it is there, the use of beta blocker, which we've said is very helpful. We also help in management of atrial fibrillation, and the use of your anticoagulants. And here, the direct oral acting anticoagulants, the rivaroxaban, apixaban, they are your first choice for this group of patients. So these are the things we need to consider. And for those with NSVT, previous history of cardiac arrest, syncope, then the use of ICD is very important in them. But ICD placements for the sole purpose of participation in sport or competitive activity, it should not be performed. It should only be done when those factors she showed us is present: family history of sudden cardiac death, unexplained syncope, and all those. The left ventricular hypertrophy greater than 30 millimeter. It's when you have all those, then those are indication for placement of implantable cardiovascular defibrillator in this patient. Then, for as regards physical activity in this group of patients, and the universal restriction from vigorous physical activity or competitive sports is not indicated. What they need to do is any young person or anybody, any individual with HCM that is going to participate in sports should have comprehensive evaluation. So it will, before they said, oh, if you have this, you cannot do sport. But now, what they need to do is undergo comprehensive evaluation. They are followed up, and there is no longer a universal restriction from vigorous physical activity for them. And like I said before, placing ICD because somebody wants to go to sports, no, it is a class 3 stuff, and it should not be performed. It should only be done when we have the all those factors in place. So, and for patients with for pregnant patients, HCM is not a contraindication to getting pregnant, but once they are pregnant, they should be followed up by the cardiologist and they should be monitored. Beta blocker can be safely used in them, but for those of them that has a need for anticoagulants, then once they are pregnant, you cannot give them the direct oral anticoagulant, so they need to be either heparin or low molecular weight heparin. The enoxaparin can be used for them. So these are the extra things I have to add to the presentation. So, but I can say Dr. Chelsea has done a really good job in telling us about hypertrophic cardiomyopathy. And so, like I said, once you have this suspicion, family history, the patient should go through those investigations we talked about: ECG, echo, Holter, then when your echo is not conclusive, then your cardiac MRI come into play. And also when you want to rule out other conditions that can also give you that level of hypertrophy. We're talking of patients with aortic stenosis, patients with amyloidosis, patients with sarcoidosis. So your MRI, cardiac MRI also comes into play to help you with this. So thank you for joining us. So I think if we have comments or question, we are ready. Dr. Chelsea is also ready to answer our questions. If there are comments, if there are questions. So you can also put your question in the chat box if you don't want to ask directly. We'll look into it. So, Dr. Williams, any contribution, any comments?
Unmute. First of all, I say thank you, Charles, Dr. Rowe, for that excellent presentation. It was thorough and up to date. So very well done. So yeah, it's about this ensure that we think about HOCM. You see an ECG that doesn't look quite right, whether it's LVH, although obviously not every ECG, as Chelsea said, is going to have an ECG. We're going to have a normal ECG, but it should be something that you think about. If an echo is done and the septum is thick, go that step further to think, oh, could this be HOCM? Then you go on forth, as we said, not to repeat all what's been said, to then go family screening. I remember that I think one footballer who did have HOCM, I think that's Fabrice Muamba, who didn't actually die. He did collapse on the football pitch, but obviously was revived. There was some form of medic on site, and he was revived, and it was all in the papers. And so it's important to think about young people as well who are in sport, that they have their appropriate screening done. And I mean, that should be a program. I'm not sure if we are involved in that, but that would be something worth talking to our government about. But again, thanks very much.
Thank you very much. I think you raised an important point there, that at least athletes, sport people at least should have a basic ECG, echocardiogram, at least a baseline done before they go into this, so that at least that gives an opportunity, because like we said, most people will be asymptomatic for most parts of their life, and you may not get to see this until someone falls down in the field of play. So thank you very much for that.
Thanks.
Can I make a comment, Ola?
Yes, go ahead, sir.
Dr. Chelsea, thank you for a very excellent presentation. I think you did the topic a great service. Yeah, I enjoyed your presentation very well. I want to kind of like highlight some of the points that we should be thinking about as well. First, let me piggyback on one of the things you said. And I just kind of want, to just be very, very emphatic about this, because it has been somewhat challenging to communicate that information to many of our colleagues, and even sometimes some of our staff in-house. And that comment is: a normal ECG does not rule out cardiac pathology. It can't say it any more than that. And then there is always this assumption that, once ECG is normal, then cardiac pathology is excluded. And that is why we have to be emphatic on the policy at HIC. We're a comprehensive cardiac center. Every ECG must be looked at by a physician while the patient is here. And there is no charge for that. And those patients who have problems needs to be flagged. And so appropriate intervention can be initiated in a timely manner. A lot of people will walk around with, like you say, 10% of persons with hypertrophic cardiomyopathy will have normal ECG. But sometimes engaging those patients with specific questions might alert you to a problem that the ECG itself doesn't show. So that's very important. Second one is, even when we talk about people with ischemic heart disease, you can have ischemic heart disease and have normal ECG as well. So a normal ECG doesn't, it's not, it doesn't, an abnormal ECG could be more meaningful in saying something is wrong than a normal ECG saying nothing is wrong. So that's one. We also have to understand some issues about the pathophysiology or the pathology of hypertrophic cardiomyopathy to understand why we treat it the way we do. Dr. Ola has, kind of like gone deeper into that. But for those of our younger colleagues, there's something that needs to be understood. About 20 to 25% of people may have spontaneous mutation. The most common genes associated beta myosin heavy chain in the isoform 7 and the cardiac binding protein C in the isoform 3 are the most commonly associated, and there's some troponin-related genes associated with this, but about 20 to 25% may have spontaneous mutation. That needs to be understood. And why we screen who we screen is also important. Dr. Chelsea alluded to that, but I kind of want to emphasize some things. The risk of sudden cardiac death, we have known predictors, and I'm going to try to list as many as I can remember. We've already talked about wall thickness greater than 30 millimeters. That is a known risk factor for sudden cardiac death. Then we also have unexplained syncope, but more specifically, unexplained non-vasovagal syncope. That is highly correlated with sudden death episode. Then abnormal response to exercise testing. Dr. Ola has spoken about that. Then we have arrhythmia on non-sustained ventricular tachycardia on a 24-hour Holter recording. That is highly correlated with sudden death. And then the first one, history of sudden death in a first-order relative. If more than one of these factors are present, it's an indication, HCC-AHA, class 1 indication for primary prevention with an ICD. And then if somebody has had if somebody has had unexplained, if somebody has a sudden cardiac death episode already, that's an indication for sudden cardiac death prevention, which will be secondary prevention with an ICD. Another thing that needs to be clearly stated is that the only thing that has been shown to reduce the risk of sudden death and prolong life is ICD implantation. But there are some observational studies that suggest that surgical myomectomy may potentially reduce the risk of sudden death and may prolong life, but that is not confirmed. But the only thing that has very strong evidence to show is ICD implantation. Every other thing is symptom relief. Mavacamten, which has been touted, is a very good medication, gives people opportunity to live more symptom-free lives. But there is no study that I'm aware of currently that shows life prolongation with mavacamten. There is another agent that is currently in, I don't know if it's been released anywhere, aficamten, which supposedly will deal with that. But if you see the myosin actin bridge delays or kind of blocking with mavacamten is different from the interstitial fibrosis, myocardial disarray, that lead to arrhythmias that are more likely associated with the higher risk of sudden death. So that has to be understood. Now, there's another aspect to hypertrophic cardiomyopathy that I think needs to be clearly emphasized. When patients have hypertrophic cardiomyopathy, we've already, spoken to the things that can increase symptoms and can reduce symptoms, or the murmur and so on. But if you understand the pathophysiology there, you also know that hydration, which is a simple thing, is a very, very important aspect of dealing with people with hypertrophic cardiomyopathy. Make sure they're adequately hydrated, because if they're not hydrated adequately, then there is a higher risk that they're going to have increased pressure gradient in the area because of dehydration. When you look at them on echocardiogram, for those interested in echo, we're looking for what we call late peaking systolic pressure. So, it doesn't look, we've had a few patients here, at least 2 patients I remember, that have had echocardiograms done and pronounced to have severe aortic stenosis, even though the aortic valves were wide open. But it's a confusion in understanding. But when you look at the profile of the gradient, you see a late peaking systolic flow, which is different, from the binomial distribution of aortic stenosis. So that is, something that needs to be highlighted, for our colleagues and for our staff, when we look at hypertrophic cardiomyopathy. The last comment I will make will have to do with the way we deal with sudden death episodes when they happen. When sudden death occurs, everybody scurries. It becomes a very traumatic event. HIC for long has had a program for screening athletes. And some years ago, we made an offer to the Jamaica Athletic Federation, and they utilized a little bit and then stopped. Then we've extended offer to the Football Federation, and they utilize a little bit and they stop until they usually call us when there is a problem. But I'm going to share immediately after this. I'll send to you, Dr. Chelsea, since this is an interest to you. We have a program we call Play Smart, cardiac screening program for athletes with a full set of questionnaire that is administered to determine who is at risk and who is not at risk. So I'm going to share that with you, and perhaps it's something that can be reactivated so that patients who have risk can be identified and the appropriate measures, taken. There are several long-term survival studies that are going on right now. One important one is Odyssey hypertrophic cardiomyopathy, and the other one is the MAVA registry study that will be concluded in 2027. And I think those will give us more insight into this very fascinating, problem, but also very traumatic when it happens. So I'll leave it at that, and then we can pick up these conversations internally later. Thanks, everyone.
Thank you very much for the comments. Thank everyone for staying with us till this part of the presentation. And sorry, the link for the CME has just been sent to the chat box, and so we can quickly fill that as we round off with the announcements. So next week we'll share the topic that will be discussed, and will let us know in time for the presentation. And then, like we said, if you have your patient for the stress echo, stress test, ambulatory test, you can send that to us, and we'll give you feedback after the test is done. So thank you for joining us, and we'll see you next week, Thursday, for another conference. Thank you very much. Good night.
Thank you everyone for taking the time out to join the presentation, and thank you Dr. Olo, thank you Dr. Williams and Prof. Madhu for your comments and clarity.
You're welcome.
Hey. Oh, come. It's like when you have these some